गाड़ी गाड़ी ये मिलेगा ना, इनोवा। इनोवा मिलेगा। इनोवा मिलेगा। हाँ, इनोवा मिल जाएगा। क्रिस्टा तो फिर सत्येंद्र जी लेके 7:30 बजे आएंगे वहां पे। अच्छा, हम क्या कहते हैं, आईजीएमएस, और आईजीएमएस में वो सब सामान उतारने के बाद वो चले जाएंगे फिर चाणक्य।
Good evening, Dr. Sinha.
Hi, sir. Good evening.
Namaskar.
Namaskar, namaskar. Great that you are in time.
At a short notice.
Most welcome.
May I do one thing, sir? May I try to share my slide and see whether they're working?
Yeah, you can do that here. Please.
Let me do that once.
Yeah, sure.
Just a minute.
Yeah. Yeah.
No, 1 minute. It was half screen. Now I'll go to full screen. It's full screen now, is it?
Yeah, it's full screen now.
You can see it full screen. Okay. Now I'm stop sharing at the moment.
Yeah, you can see the second slide also. You can pass on the second
Okay,
slide.
that's okay.
It's all right.
It's open.
Fine.
It's open.
Yeah.
We have got 4 or 5 minutes time. So
Yes.
you are actually conducting this. Very nice, sir.
Yeah.
How frequently you do it? Every month or every week or
No,
what?
this is done every week.
Oh, that's great.
So we had 3 classes so far. First, there were note takers, so I took it. Cardiology A to Z. That was my topic.
Oh, that's great.
Yeah,
Excellent.
and then Dr. Astos is an electrophysiologist in Hyderabad. He's from
Yeah.
Bihar, and he is disciple of Dr. Tiwari.
Oh,
Yeah, he got education there only. So he did the second program on cardiac arrhythmia. That was fantastic, very good. And what we have decided, Somitro, that we will have a summary of everything written by each of us. And then finally, at the annual function of CSI API, this book will be released.
oh,
That will
that's
be
very nice. Very nice
yeah,
endeavor.
compendium of whatever. Like,
Excellent.
yeah. I've requested everybody, all the top people like Wonder, Gurpreet Wonder. Then I've requested Chopra ji also. Chopra ji also for us.
He's always enthusiastic. He can do anything.
Yeah. So let Dr. Tiwari come, in 1-2 minutes. Dr. Tiwari sir, are you there somewhere? He will come, definitely he'll come.
And is it an all India program, sir?
This is all India program. But normally, we are seeing a attendance of about 60, 70, 80 like this.
Oh, yeah, sure. Juniors are busy. Actually, they have got so much work to do in the ward and their thesis work and everything.
Yes.
So how are things at Patna?
Patna, things are okay. Medanta, we are in Medanta. I am in Medanta. So things are okay in Medanta. They are doing well. Fact.
What about your new airport? Is it coming up?
What, sir?
New airport?
Oh,
I heard
new
there was
airport.
going to be.
No, new airport. I mean, this gone a bit of slow progress. I don't know whether it will be there or not.
Oh,
Yeah, not yet. They are confusion about the location.
it is a bit far away from Patna, isn't it?
Yeah.
Quite.
So they are trying to expand their airport is refurbished now. It will from April it will start, a new airport will start. The new building, they have all the tarmac.
That's better in the same place, but in a modern look. Yeah. That will be good. API are taking a lot of initiative for continuing medical education.
Yes.
Doing a very good job in
Yes.
classes and monograms and publications and Very good teaching programs going on. So you told me yesterday, na? So I had to rush through my previous talks and slides and to find out cases.
We are waiting for Dr. Tiwari if we can manage to. We have already 40 plus people already joined. Yeah.
I'm ready. Whenever you ask me, I'll start.
Yes, yes, yes.
Sir, Kamlesh sir is now joining.
Dr. Sina, who are the audience today? Who are the delegates? Please unmute, sir.
Our delegates are mostly PG students. Dr. Tiwari is come.
Yeah.
So good evening, sir.
Good
Hi,
evening.
sir. Good evening.
Good evening, sir.
So I request Dr. Tiwari to bless the occasion with few words, because we have Dr. Somitro, who is at least in CSI group. He's a celebrity. So I have managed to bring him. So sir,
Thank you,
a few
Dr.
words.
Ajay. Thank you. Actually, this is short certificate course started by ICP. This is a direct class between teacher and students. Students means doctors, PG doctors and post-PG doctors. Actually, what I thought in the beginning that in the most of the medical colleges, there is no teaching at all nowadays. And there are many new colleges nowadays which has got PG degree, but there is no teacher there. So I thought, why not to teach in a class of those students? That's why I started these classes of each subject. Every day we are doing one class for 1 hour for this PG and post-PG students. And I
Yes.
think this is going very well.
Yes.
Today is the day of cardiology, so it will go with you,
Yes.
Dr.
So,
Thank you,
Ajay.
Dr.
thank you,
Tiwari.
sir. Thank you, sir.
Thank,
It's a
thank you.
great motivation from your side, and I'm thankful to all the API stalwarts. Many of them are not known to me because I never remained in the API hierarchy. So I thank all the top stalwarts in API, Jyotirmay Paul, Dr. Tiwari sir, who is the dean of this prestigious organization. And the whole idea is to educate junior doctors, our rural, especially those who are working in rural areas, and all the PGX students across the country. And this is the third class we are going to have. And I'm thankful to Somitro, because, I request him only once, I requested him that, sir, we are in, tomorrow we can we have a class by you? And generally it's very difficult for a person like Somitro Ray to, do this in a very short notice. But he has been kind enough to listen to me, and in 1 hour time he said yes. Then I conveyed to Dr. Kamlesh Tiwari, sir. And the last program was a program on arrhythmia done by Asutosh. That was an excellent program. I tell you, phenomenally good program. Those who have attended it must have realized. Those who have not attended it, they will miss it. We'll try to, provide them with the material. So, Dr. Soumitra Ray is an ex-professor, Vivekananda Institute of Medical Sciences. He is Vice President, Cardiology Society of India, and he had pursued his MRCP from UK and MD from Calcutta Medical College. He is trained in interventional cardiology at London Hospital, London. He has published nth number of articles and publications, and his articles rank among top 8 of the worldwide cardiology from 2013 to 2023. So it's a very kind of proud feeling for all of us, those who are in India. And he has been on editorial board of Indian Heart Journal, Journal of Diabetic and Dyslipidemia. He has represented many international and national conferences. And over to you, Dr. Samitra Ray. He'll be focusing on case-based presentation of cardiology cases, especially the clinical cardiology. So with Dr. Tiwari's permission, I'm handing over
Go ahead, sir. Go ahead.
Yes, to
Thank
Samit.
you.
Thank you,
Thank you,
sir.
Dr. Sinha. Thank you, Dr. Tiwari. Dr. Tiwari, you are respected by all physicians in India, and this time also we enjoyed the Epicon. This time, for your information, Dr. Jyotirmoy Pal asked me to make the cardiology portion of the program. So I was actually responsible for the cardiology part of the scientific program. So I was very much part of Epicon this time.
Thank you, sir. Thank you. Thank you.
And this is such a good endeavor. And Dr. Sinha, though you asked me only yesterday, but I can't say no to him. He's such a father figure to me. If he asks me to do anything, I can do as unless it is absolutely not possible. But I had to crunch through all my old memories and my data set and everything to find out the preparation for you today. So all my junior colleagues, my teachers over here, as I realized that many of you are PG students and taking exams. So in exam, the complicated cases, the intricate things are for once you start practicing. But to pass exam is more important to go through the simple things where there is no excuse. If you miss anything very simple and fundamental, then examiner won't forgive you. But this is a very complicated case, controversial thing. Then, well, you can always argue and you can still always pass. So I deliberately kept two very simple cases for you. Let's see whether we can get anywhere with that. And if you get anything, take home. My first case is a case of recurrent acute coronary syndrome. By the way, you know that only today, in ACC conference, new guideline has been published for STEMI and non-STEMI. So there are exciting things over there. So maybe within the next 7 days, you can go through that and we can have more seminars over the next few months on the new guideline of non-STEMI and STEMI by ACC, which is just published today. But today's case is not related to that. This is a middle-aged man who is a smoker, presented with ACS, with ST depression in the lateral leads. It was pre-COVID. Troponin I was high, and he was drug naive. He didn't know anything about his disease, or he never checked much. So naturally, we did an angiogram, and we saw a very tight lesion in the circumflex and a borderline lesion in the LAD and a plaque disease in the right coronary. I think you will agree to our observation. And as the changes were in the lateral leads and troponin was positive, left circumflex was stented with a drug-eluting stent. We did the LAD FFR because it was about 40-50% lesion by eye estimation. If you see, it is around 40, 45, 50. So we did an FFR, which was negative. So we left it alone. And among other standard therapy of dual antiplatelet beta blocker ACE inhibitor, we gave rosuvastatin 40, started from day 1. His ejection was preserved. There was no regional wall motion at the time. On admission, the LDL cholesterol was 115. TG was okay, and HDL is typical Indian HDL of around 34. After 6 months, he came back. Actually, he was not a very regular patient, as you know that he didn't do any checkup before. And at that time, the LDL was 84. Remember, it was 2018, and LDL 84 was sort of acceptable at that time. HDL triglyceride remaining the same. So I continued with rosuvastatin 40 at that time. But what happened, this was in June. In October, he came back with another acute coronary syndrome. This time again non-STEMI, both are non-STEMI with inferolateral ST depression, and troponin was strongly positive. And what we found, if you see, the circumflex stent was well patent. LAD lesion has progressed from 40, 50 to it is almost now 80, 85. And also that's a bad thing. And very surprisingly, the right coronary, you see, over about 8 to 10 months, from minor plaque, it has become almost a 99% lesion. So, and a very successful stenting was done, this time both to LAD and RCA. Now, patient was on rosuvastatin 40 from day one, and he was tolerating well. Last LDA was 84. Now, in 2024 or 2025, you won't accept this 84 value when the patient comes back. And of course, you will do something about it. Rosuvastatin 40, you can add ezetimibe, you can add other medicines, you can add evolocumab, even you can give inclisiran. But at that time in 2018, 2017, it was not so common to use these medicines. But when it was still 84 and he came back with a second episode, I gave 140 milligram of evolocumab on day one of the second PTCA, along with rosuvastatin 40 milligram. Of course, inclisiran was not available at that time, and ezetimibe was not so very common at that time. I'll come to that discussion later on. After 1 week, just after 7 days, his LDL was 37. That is what we need. Even the TG has come down to 93. It was in the range of 150. HDL is unchanged. You cannot affect HDL so well. But this is very satisfactory after a week. And if you see the chart for next 1 year almost, 2019, you see, I gave Repatha. I cannot give Repatha as per recommendation because of patient's financial constraint. So in October 28, I gave the Repatha. And then again in November, I gave another Repatha. In December, I gave another Repatha. I couldn't give twice a month, but once a month, at least I could maintain. Then in February, and then in April, we gave Repatha, quite a few doses. And you see, LDL was consistently around 40 or below 40 over after the second episode. So 115, then 84, then it was very nicely controlled. In retrospect, if I could have reduced this 84 in June 2018 to the level of 40, 50, then I might have avoided the second episode of acute coronary syndrome. So it is a retrospective thought, but nowadays it is a very common practice, an usual practice. But at that time, it was not so common or so usual. HDL, I couldn't do anything. Triglyceride, of course, was reduced. Very interestingly, his LPA, we didn't do it at the beginning because, again, that was not very fashionable to do LPA in 2017-18. But later on, when after the second episode, I did the LPA, and I found it to be 68. And that was after the first dose of Repatha. So might be it was more. You see, from within next 3 weeks, in 31st October or in November, from 68, it became 97. Then I gave Repatha again, but it became 115. And then another Repatha, it was 71. So we know that evolocumab can reduce LPA, but not very consistently again, you see. Even on evolocumab continuing, it was fluctuating. It actually increased from 68 to 97 to 115, but again, it is coming down. So what is the role of LPA in atherosclerotic cardiovascular disease? So that is a scenario of the case. And I tell you, I saw this patient about 2 months ago. He's in regular follow-up now. He's doing absolutely well. He is no longer taking evolocumab, but with highest dose of rosuvastatin, with ezetimibe, and the third drug also, bempedoic acid. So I'm giving the 3 medicine now. his LDL cholesterol is between 40 to 50. So now with triple therapy, we can achieve below 50 LDL in majority of patients, though maybe in this case, my target will be 40 or even 30. That I cannot achieve perhaps with these 3 drugs. I asked him to take an inclisiran or Repatha, but he refused for the moment. He said, I'll do lifestyle more and I'll see. So patient is okay at the moment, no further problem. Now, if we go to a little discussion about the management of dyslipidemia in acute coronary syndrome, we published this CSI guideline only very recently as part of that guideline. So if you see, we have got a few differences from the international guideline, ESC and SEC guideline. What we have emphasized that as soon as the patient comes to the emergency, along with the usual blood, you send a lipid profile, and it is non-fasting lipid profile. We never wait for the next day morning to have the fasting lipid profile. So that is a dictum now. You must send a lipid profile non-fasting as soon as the patient arrives in the emergency. And then blindly, you give 40 rosuvastatin with 10 ezetimibe or 80 atorvastatin with 10 ezetimibe. Whatever be the patient be on, drug knife, other medicine, whatever he is on, just give 40 or 80 plus ezetimibe without waiting for the LDL result. And here also very interesting, we are saying 40 and 80. We are not saying the high dose of or high intensity of rosuvastatin, which is 20 to 40. So we are not compromising on 20. And atorvastatin is 40 to 80. We are not compromising on 40. We are telling go to the highest dose. If the patient not tolerate, that's a later story. But at the moment, give 40 E or 80 AE. Now you check at 4 weeks. Here is another difference. Most guideline you will see 4 to 6 weeks or 4 to 8 weeks. But we have found by extensive study by our centers in India that nothing changes after 4 weeks. Whatever lipid alteration will happen with a medicine will happen within 4 weeks. If you continue the same dose, you won't get any further benefit. So don't lose another 2, 3, 4 weeks. At 4 weeks, you check the LDL. If it is below 55, you are fine for the moment, unless there is a second episode. But here, at 3 months follow-up, we are asking to check not only the LDL, but non-HDL as well. Because we know in Indians, because of the triglyceride issue, VLDL, IDL, chylomicron issues, there sometimes is a disparity between LDL and non-HDL. By international guidelines say when LDL plus 30 is your non-HDL. But in many Indian patients, you will see that non-HDL minus LDL is often more than 30, 40, 50, etc. So you have to achieve both the targets, not only LDLC, but also non-HDLC below 85. So, but that is not immediate, that is after 3 months. Now, if you come to the right side, if you see at 4 weeks that LDL is not yet below 55, you add bempedoic acid because he is already on 80 or 40 atorva or rosuva plus ezetimibe. So you add the third agent available, that is bempedoic acid, unless contraindicated. And again at 4 weeks, you see total 8 weeks. So another 4 weeks, if it is below 55, you go to the left path. If it is still above 55, so 2 months after the acute coronary syndrome, 8 weeks after the acute coronary syndrome, you are deciding whether the patient needs evolocumab or inclisiran. Okay? And at 12 weeks, that is at 3 months, you have to achieve the goal of both LDL and non-HDLC. So we are much more aggressive in our approach. So we said hit hard and hit early. That is our CSI guideline. If you go, there is another organization called Lipid Association of India. If you go by LAI guideline, they are even more aggressive. They are saying go to 40, but they are saying triple therapy in the emergency, followed by target to be 30, 40, very high risk patient 30, and their threshold for giving the injection therapy is much lower. But we are maintaining a middle path because of, number one, lack of very hard evidence for that, and number two, considering our socioeconomic condition and very poor insurance tech in India. If we see what are the difference, as I mentioned, that non-fasting lipid we are emphasizing. Bempedoic acid is the first time we are saying, because it was not approved by most countries and so it was not in their guideline. 3-month non-HDLC we are including as a compulsory assessment, and PCSK9 and inclisiran we are giving very early. Only exception to this rule, if you go to the upper right corner, very elderly patient or frail patient or advanced CKD, then we are starting with a lower dose of atorvastatin or rosuvastatin, that is 40 and 20 respectively, rather than 80 and 40. There's the only exception. And if recurrent SCS occurs, goal should be of LDL below 40, non-HDL below 70. So from 55 and 85, these have become 40 and 70. So my patient, after the second episode, deserve to have the LDL below 40 and non-HDL below 70. And I should offer the patient at least that you should go take these medicines to achieve this. If there is statin-associated muscle symptom, new onset diabetes, worsening HbA1c, then we can down titrate the statin from 40 to 20 rosuvastatin or 80 to 40 atorvastatin, followed by another profile, and it is above 55, then start bempedoic acid. So that is another caveat of this approach. Why we are in India getting so obsessed about lowering LDL? Because we know that it is quite an old slide, 2017 Barcelona, it was presented in ESC Congress. Incremental benefit with LDL reduction in primary endpoint. If you see above 100, if you say 1, then 70 to 100, you get 3% benefit only. From 50 to 70, you get 6% benefit, extra benefit. From 20 to 50, you get 15% extra benefit. And even below 20, you get 24% relative risk reduction. So even below 20, there is evidence of relative risk reduction, incremental benefit. But again, it was a secondary analysis, and you know, by statistical jugglery, we cannot take any secondary endpoint as an object of changing guideline. Why we are starting with ezetimibe on the day 1? High intensity statin with ezetimibe. Why do we choose it as an initial treatment? Because we have shown in Indian patients that primary and secondary endpoints are, if we see, in group A is that when we give the high intensity statin only, and group B when we give the high intensity statin plus ezetimibe to begin with. And in both situations, primary and secondary endpoint, you see there's a huge benefit if we start it, the dual therapy to begin with. If high intensity statin and ezetimibe group A, we achieve the target in 76% of patients. Vis-a-vis, if we stick to high intensity statin only for 4 to 6 weeks, then after 4 to 6 weeks, we achieve the target only in maximum 50% of patients. So clear 25% of the patient remain unprotected for 1 or 2 or 3 months. And you know that ezetimibe is cheap, it is available, it has got no side effect, it has got no drug-drug interaction, etc., etc. So why don't you give this harmless medicine to begin with? Bempedoic acid we are not giving to begin with because there is some side effects of bempedoic acid like high uric acid or biceps tendon rupture, etc. So we reserve it for those patients who require it, not to give it blindly. So that is our logic of CSI guideline. But why the PCSK9 is becoming the target? The more the days go, you will see more and more research on different aspects of PCSK9 targeting. What is the PCSK9 actually? PCSK9, what is this? PCSK9 is a protein which is synthesized in the ribosome inside, and PCSK9, we can block, we don't want PCSK9. That is a very fundamental thing. PCSK9 is our villain, is our enemy. So we have to stop PCSK9. We can give a monoclonal antibody which will bind the PCSK9, or we can stop the synthesis of PCSK9 by small interfering RNA, serina, that is inclisiran. Or even the third approach nowadays is gene editing, so that even at the genetic level, PCSK9 is not being produced. Why PCSK9 is bad? Because PCSK9 competes with the LDL receptor at the hepatocyte, so that the LDL is not taken up by the receptor because it is blocked by the PCSK9. If LDL is not taken up by the receptor, there will be more LDL in the blood. So we want to remove this PCSK9 from the LDL receptor so that LDL receptors are free to operate and engulf and destroy LDL cholesterol. So how to stop this PCSK9? As I told, there are 2-3 ways of stopping PCSK9. Impact of anti-PCSK9 antibody on LDL receptor expression. And if you stop this PCSK9, LDL receptor will increase. Importance of expression of PCS. If the PCSK9 increases, then LDL receptors are less, so LDL cholesterol will increase. If you destroy the PCSK9 by whatever method, your LDL receptors will be free and available, and LDL will be reduced from the blood. And it has been shown on very strong basis of Mendelian randomization, for genetic studies, as well as therapeutic intervention by evolocumab and inclisiran. What basically fundamental difference with statin with this PCSK9 approach? Suppression of PCSK9 synthesis increases LDL receptor level as well as activity. Statins actually increase PCSK9. So statins effect is not fully observed if there is high level of PCSK9. So if you give something to oppose PCSK9, the effect of statin will be very much augmented. So actually it is a complementary effect with statin. So people say that you should actually use evolocumab or inclisiran on statin. Then you get the full benefit. If the patient cannot tolerate statin, you may give it, you will get benefit, no doubt, but the benefit will be much more augmented if you give it on top of statin. So that is the fundamental issue. How can PCSK be reduced? As I said, monoclonal antibody like evolocumab. These are very expensive. You have to give 2 to 4 weekly injection. You can give small interfering RNA, which can block the synthesis and which has to be given every 6 months. So 2 injections per year. Or genetically, you can gene editing on platforms. Then it is now coming up, gene therapy. You may see in next 3 to 5 years. So what is the background of this inclisiran? I don't go into the detail. You can read because it can come as a short note, or you can encounter it in the Viva, because it's now quite popular in India. Of course, the cost is a problem, but certain government segment and insurance are allowing it. So people are taking inclisiran. So it is a subcutaneous administration, and you can see the precipitous fall of LDL cholesterol. 60 to 70% fall of LDL cholesterol starting from 7 to 10 days. So it's a very fantastic molecule to start with. If you give injection 1 and injection 2, and in 30 days, you get a 60% reduction, which is maintained for next 3 to 6 months. And 1 dose and 2 doses of inclisiran up to day 180, efficacy of 300 versus placebo, you can see. The first 2 doses should be at 3-month interval, then every 6 months. If we sum up, a vision for innovation of a CVD anticipated product profile, statin, say evolocumab, and say inclisiran. Efficacy-wise, those two are more effective than statin. All are more or less safe. Adherence is much more with inclisiran. Patient satisfaction is much more with inclisiran. Value opportunity varies on long term or short term. As the Kaushik Ray's group from Oxford, UK, are doing great research on this, and they are saying that every time you take a medicine or take an injection or tablet, it's an encounter, it's an effort. So for statin, you have to give this effort 365 times every year. For Repatha injection or evolocumab injection, twice a month, you are giving 24 efforts, that is 12 months, 24 efforts every year. And for inclisiran, you are giving 2 efforts every year. So your chance of missing a dose is much, much, much less with inclisiran as your effort is reducing. And that steeply increases the compliance. Compliance increases means your LDL is consistently reduced. And nowadays, as you know, that we are talking about blood sugar variability, we are talking about blood pressure variability. Now we are going to talk about blood cholesterol variability. So it is not only enough to keep the LDL down, but it also important to remove the fluctuation of LDL cholesterol. Some month it is 30, some months it is 48, some months it is 25. This is bad. Rather, you maintain 40 steadily every month. That will give you better result. So this is another concept for which compliance is very important. I finish this part of the subject, not finish, I'll have another small bit, by Eugene Braunwald in Munich ESC 2018. I was lucky to be present to hear from him directly. He said, coronary artery disease 10 years from now, my predictions and how to get yourself ready. That was the heading of his talk. It is a fantastic talk. You know, whenever Braunwald talks, you are just magic. He said, CAD remains the most important arterial disorder, responsible for an enormous number of deaths and morbidity. So it almost goes without saying that efforts to reduce its incidence are incredibly important. I can see advances in 3 main areas, very categorical. Each a soldier in the battle against CAD that will really improve the way we go about tackling this disorder. First approach concerns the development of non-invasive coronary artery imaging. And you know more than me that how we are advancing in that front, so that in one non-invasive imaging, we will know the anatomy, the physiology, the plaque character, everything from outside by combining different modalities. Days are coming, very exciting days. The second area is the use of genomics to ascertain and define the risk of coronary artery disease with greater precision. So precision medicine, in every branch of medicine, you're talking about precision medicine. No 2 persons are similar in their genetic makeup. So they are different in their pathological makeup also when they develop a disease. So we have to hit the pathology precisely rather than giving a blanket treatment. Last approach, which in my opinion is the most interesting, has to do with the new drugs developed. In the last few years, monoclonal antibodies to inactivate circulating PCSK9 and thereby lower low density LDL cholesterol has attracted great attention. Scientists have now developed a new drug, inclisiran. The real advantage of this drug is that it needs to be administered only every 6 months or even yearly to lower cholesterol. Given that inhibition of PCSK9 production will be able to actually prevent coronary artery disease if begun early enough in a person's life, I would propose it as an outrageous suggestion. Look, he himself says it's an outrageous suggestion. Maybe he is 50 years ahead of his time, that such a drug be administered on a regular, once or twice yearly basis to everyone over the age of 30 years. What a statement from a person like him, from a forum like ESC annual conference. This approach would have a profound effect on reducing the development of CAD in populations. The cost of delivering such a drug, of course, would be outweighed by the reduction in healthcare costs associated with treating people with established coronary artery disease. However, this approach will have to be shown to be feasible and safe. So that was a mesmerizing talk, and that was in 2018, I said, no? 2018. So 7 years down the road, 6 years down the road, we are seeing these statements, how wise this old man is. They're coming to life, his words. Now, 2-3 slides on this first case. We are talking about LPA. I mentioned about LPA, isn't it? LP is highly prevalent, not only in India, but also worldwide. And if you see the world map, India has one of the highest prevalence of LPA. And there is geological reason for that. Africa and Asia, you know, were a same mass. Then by shift of land, by the ocean, they were separated. But this high LPA gene originated from that Afro-Asian areas. So still they are carrying this gene. We are carrying this gene along with our African friends. But other areas of the world, particularly North America, they show a very, and Russia, they show a very low incidence and prevalence of LPA. LPA is both the most common monogenic cardiovascular risk factor. This is very interesting. Commonest monogenic, so far identified, cardiovascular risk factor, commonest is LPA, and one of the strongest genetic risk factor. Elevated LPA is not rare, about 20% of world population having high LPA. More than 1.4 billion people are estimated to have elevated LPA. In comparison, familial hypercholesterolemia, again a monogenic, has an estimated prevalence of 1 in 300. Here it is 1 in 4, 1 in 5, rather than 1 in 300. But we talk so much about familial hypercholesterolemia, we hardly talk about LPA. The reason being, we thought even 3-4 years ago that LPA is fixed in value for your life. You are born with, say, value of 40, you die with value of 40. You can't do anything about it. And there is a very funny statement given in most of the guidelines that you check your LPA at least once in your lifetime. It's not a cosmetic thing to check and to know your LPA value at the age of 80 or 90 or just the day before dying. Now we know that you can manipulate LPA. If you are born with 70, you don't have to die with 70. You can reduce it to 40 or 30 so that your coronary disease is decreased. You can manipulate. So it is important to know, not at any point of your lifetime, but with the first time when you are checking your lipid profile. So that is a dictum now in India. Check your LPA on the first occasion you are checking your lipid profile, which should ideally be at the age of 18, unless there is more compelling evidence to do it earlier. LPA is an inherited, independent, and causal risk factor for ASCVD. And there is enough, again, meta-analysis study, Mendelian randomization, GWAS, genome-wide association study, everybody showed that LP is so important. Another disease where LP is very important is aortic stenosis. So these are the two important diseases which are associated with high LPA. And they increase the risk of cardiovascular disease by 3 to 4-fold risk of various disease of brain, of heart, of kidney, of general atherosclerosis, etc., etc. What are the options of LPA lowering nowadays? Statin, if anything, does not change LPA, rather it might increase LPA a little. That is very bad thing about statin. Ezetimibe is really not helpful. Only thing so far good is lipoprotein apheresis, real reduction, but it is not feasible. You have to, lifelong, you have to be hooked to 24 hours apheresis at least twice a week. So that is not quality of life. Bempedoic acid, basically no change. Now this evolocumab, about 25% further reduction. That's why you remember I gave evolocumab for LP as well. Inclisiran around 20%. But good days are coming. We have got pelacarsen, we have got olpasiran. Olpasiran is again like a small interfering RNA, just like inclisiran. There is olpasiran, and they can reduce up to 90%. And they're targeted, you see, they don't work much on LDL. They work targeted on LPA. So good days are coming. So we'll talk more and more about LPA. So should I go ahead with the second case, or there will be some interaction at this stage? Dr. Sinha?
We can go ahead with the case.
And then if the time left, then we can do it. Okay.
Yeah,
The
sure.
second, apart from lipid with ACS, now there is a case of hypertension. You say, oh, it's a wastage of time. Many you will log out because you know that hypertension everybody knows. Let's see. The case is that a 50-year-old, again, and middle-aged man, corporate executive, very high flung, divorced, living alone. You know, in your exam, whatever exam you take in your life, you will realize that whenever a case scenario is given, every word is important. Unless it is said by a very stupid examiner, any sensible examiner, when giving you a case scenario, every word carries some meaning. There is no unnecessary word there. So divorced and living alone. Smoker, 10 a day, socially take alcohol with irregular eating habit as the corporate gurus do. Long-term fatigue and feeling low, maybe depression, living alone, and mild shortness of breath because of smoking. That's how his GP thought it was. He was medium build with 66 kg weight and BMI, quite good BMI, 23.5, normal BMI. Waist circumference is 35, is anybody's will be jealous. Pulse is good. BP is not controlled. 160/90, both arms, sitting, no postural change, all limbs equal. Mild pitting edema and JVP is normal. So maybe this edema is due to amlodipine or something. JVP is normal. Other systemic examination are normal. There's mild wheezing, is smoker's lung. Now, baseline investigation are recommended by most guidelines. When you get a case of hypertension, you do a certain things, including the full blood count, which was normal. Sugar level was normal. Cholesterol, maybe by today's standard, is not good. 102 is not good of LDL. And triglyceride is, of course, a bit high. Sodium, potassium, okay. eGFR is 80, just started to fall. Uric acid is okay. Liver function normal, urine routine normal. ECG and echo both showed left ventricular hypertrophy with some evidence of diastolic dysfunction. So what we did, as BP was graded 2, 160/90, and there is evidence of target organ damage. Nowadays we call it HMOD, hypertension mediated organ damage. And that was left ventricular hypertrophy, which is the most easily picked up HMOD. Pharmacotherapy started along with lifestyle measurement. And as per guideline, we have to give a dual combination as a FDC, and we started telmisartan chlorthalidone because there is already a little ankle edema. So we thought maybe amlodipine or CCB will cause more edema. So we gave telmisartan and chlorthalidone. At 6 weeks, still it was 152 by 90. So amlodipine had to be added. And again, as a fixed dose combination, I added the triple combination of FDC. Another 6 weeks, 146 by 84. By today's standard, 130 by 80, even at that time, 146/84 was high. Even by 140 by 90 standard, it was not controlled. So what to do then? Now he is a case of resistant hypertension because there are 3 drugs, including a diuretic, and pressure is not controlled. Very simple. So the thing comes whether it is pseudo-resistant hypertension or true resistant hypertension. So we do an ambulatory blood pressure monitoring, and it was hypertension, even at home. And pseudo-resistance causes were excluded. What is this resistant hypertension? It is not a disease. It is an indicator that this hypertension is going to cause harm. It has got bad prognosis, and it may have secondary causes. This is the implication of resistant hypertension. It is not a separate disease. Risk of stroke, MI, renal disease, death, they are increased by 2 to 6-fold with resistant hypertension. And there are many things you have to look into. Pseudo-resistance, as you said, by whether you are checking it with the proper way. You know, there are 6-7 criteria given by the guideliners how to check a blood pressure. You have to exclude white coat hypertension, so you must do a home blood pressure or ABPM. You have to check the compliance. That is sometimes very difficult, maybe tablet count by close encounter, and secondary causes. So current definition of resistant hypertension just came last year with the ESC guideline. Hypertension is defined as resistant when a treatment strategy including appropriate lifestyle measure. This phrase was not there before. And treatment with maximum or maximally tolerated dose of a diuretic, which has to be thiazide or thiazide-like, a RAS blocker, and a calcium channel blocker, failed to lower office systolic BP below 140 and diastolic BP below 90. These, by ESC 140/90 is the standard, not SEC is 130/80. These uncontrolled BP values must be confirmed by out-of-office BP measurement. This is the definition, which is quite a comprehensive definition. And what are the main issues? Resistant hypertension is not a disease, as I mentioned, but an indicator that should be used to identify patient at high risk for complication and possibility of secondary hypertension. Pseudo-resistant must be excluded. With decreased eGFR, when really reduced below 30, an adequately uptitrated loop diuretic is necessary to define resistant hypertension. This is very interesting statement, which was not there before. So it is, you see, in the original definition, it is thiazide or thiazide-like diuretic. But in case of eGFR below 30, you have to give a proper dose of loop diuretic and not banking on thiazide-like diuretic. Then only you can call it resistant hypertension. So this is an interesting insertion. Patients with suspected resistant hypertension should be referred to specialized center, and conditions found to cause this kind of thing: poor adherence, white coat, poor technique of measuring BP, marked brachial artery calcification, clinician inertia, Munchausen syndrome, and causes of resistant hypertension. Why the lifestyle measurement is initiated? Because there is causes include overweight, obesity, physical inactivity, sodium intake, habitual alcohol intake. This can cause high blood pressure. Use of drug or substance that may increase BP, including licorice, Chinese herbs, they can increase blood pressure. NSAID, they can increase blood pressure. Undetected secondary hypertension. Naturally, the thing comes, what are the common secondary hypertension? There are 5 common secondary hypertension. Primary aldosteronism, renovascular, pheochromocytoma, obstructive sleep apnea, renal parenchymal disease. So renal parenchymal disease, you do the creatinine, sodium, potassium, EGFR, etc., urine dipstick, renal ultrasound. For renovascular, you do renal Doppler, abdominal CT, angio, or MRI. For primary aldosteronism, AR ratio, aldosterone-renin ratio, and by reviewing the potassium level when the patient was not on any medicine. Pheochromocytoma, you know, the 24-hour urine or plasma, and obstructive sleep apnea by polysomnography. And there are certain other things which are hormonal and rare. So what you do when you encounter a patient of resistant hypertension? You check the patient thoroughly. Café au lait spot, which can give the diagnosis of pheochromocytoma. Kidney palpation, renal enlargement, could be polycystic kidney. Auscultation of heart and renal artery for murmur or bruit, maybe aortic coarctation, maybe renovascular hypertension. Comparison radiofemoral, again coarctation. Cushing's disease, you know the feature. Acromegaly, you know the feature. Thyroid disease, you know the feature. So these are all physical examination. In my case, what happened? USG was normal. Renal artery Doppler was normal. We did it because we have to find out whether we're missing some secondary cause. Endocrine thyroid function test normal, electrolytes normal, potassium normal, calcium, magnesium. Coarctation of aorta was not there, no physical clue, chest x-ray, echo. Obstructive sleep apnea, we didn't think because BMI was 23.5, so we did not consider it. So we excluded. And corroborative history like drug, contraceptive, diet, even otrivin, nasal decongestant, xylometazoline, oxymetazoline. People forget to tell that because they think it's not medicine. They can actually keep the pressure up. Licorice, as I said. Rare genetic causes, you can read those. I am not going into that. So what to do? We have already discussed these common causes. Now we are baffled. Why this pressure is so high? We didn't get anything. So I said, okay, let's admit the patient and see what is happening. Sometimes many things people don't disclose what they do at home, but in hospital setup, it might be, in a closed environment, you know what is happening. Being clueless, the patient was admitted to hospital for observation. That night, nobody in the ward could sleep. Only the patient was sleeping. Why? Because he was snoring like a giant. And the sisters complained to me, sir, what to do? We are very restless. All patients are complaining. This man is snoring like like anything, like bomb blast. Following night, polysomnogram was arranged. Diagnosis of obstructive sleep apnea was clinched. CPAP was introduced. Blood pressure came down to 136/80 only after a month. And only amlodipine and telmisartan, even the diuretic was out. So you see what misled us. He was divorced and was living alone. Usually obstructive sleep apnea is complained by the partner or the spouse. He or she is snoring. But here, nobody here to complain about the snoring. That is very, very important clue, which we missed, that we could not get the sleep history. Many times, the wife says he's snoring, he's sometimes getting stiff, his mouth, he gets kind of agitated, he wakes up. All this history, patient cannot give. Though some people argue the nose is so close to ear, so why doesn't the patient hear his own snoring? I have no answer to that, but anyway. So snoring is detected by the partner or other family members. Here, nobody was there to complain. Then I would have changed the diagnosis much earlier without going through all this. Second misleading thing was his body weight. He was rather on the thinner side. 23.5 was his BMI. Now, after literature search, I found at least 25 to 30% of people with severe obstructive sleep apnea are thin built. So not necessarily they have to be obese. But there are certain physical measures, your neck height, your body height with the neck height and so on. You can go through those. So as I said, these were, and he was thin, waist circumference was 35. So it's a thin person. So these are the things which can be associated with obstructive sleep apnea, including alcohol and smoking, including endocrine disease, age, sex, race, genetics, large neck, obesity is of course there, and proportion of head and neck, the configuration. There are three types of sleep apnea. Obstructive, most common type, in which the airway is narrowed, blocked, or floppy. Central, no blockage of the airway, but the brain doesn't signal the respiratory muscle to breathe. Brain also sleeps while the man is sleeping, and there could be a mixture. How to diagnose? As I said, symptom. We mentioned at the beginning, daytime drowsiness and lack of clarity in the morning. We thought he is depressed. Headache, feeling disgruntled, forgetful. We all thought because of divorce and he's alone, he's under pressure, depression, poor job performance, loss of interest in sex, leg edema, snoring. Signs, obesity is about 2/3 of cases are obese. Children with large tonsils and adenoids. Very important to have an ENT checkup. Collar size more than 17 inch for men. This patient has 19 inch. We are looking at the waist circumference, 35 inch. We are so happy. But we never looked into the collar size. So not only your trousers are important, your shirts are also important. So you see, just not the trouser, your shirt is also important. Your collar size, not just the trouser size. Large tongue. Now we detected he had a large tongue. We never asked him to stick your tongue out. Now we see that his tongue is big, genetically. Retrognathia, the lower jaw is retruding. A narrow palate. So you have to have a good examination. If you cannot do it yourself, send him to an ENT specialist. And snoring, apnea, morbidity, early death. So this is the patient's life history of sleep apnea. And polysomnogram, you have to have a working knowledge about polysomnogram. It can come as a short note. There could be 5 channel, 7 channel. There are different types, measures you can do. EEG, electrooculogram, electromyogram, electrocardiogram, pulse oximeter test, ABG, etc. throughout the night. And this is how a typical thing looks like. EOG, EEG, EMG, EKG, SNA, respiration, etc. Treatment, weight loss, nasal decongestant. Now you have to give it, or antihistaminic. CPAP is the treatment of choice, or BiPAP, very rare. Positional therapy, how to get a clear airway. But very disappointingly, CPAP has shown to improve quality of life, very much quality of life, very much body weight reduced with CPAP, but we still couldn't prove that CPAP reduces sudden cardiac death or heart failure or new onset atrial fibrillation or coronary disease, which are the complications of obstructive sleep apnea. And this is the how we do the treatment algorithm. AHI is a good index. Apnea, hypopnea index. Apnea versus hypopnea. And this is how they go by AHA. As the AHA increases, your chance of events are increasing. I'm not going into that. And there are surgery, of course, uvulopalatopharyngoplasty if it is an obstructive type, tracheostomy in extreme cases, and other surgical procedure, bariatric surgery, etc. So this is the last ESC guideline of the hypertension. Summary of obstructive sleep apnea as a common form of secondary hypertension. Restlessness, intermittent sleep, recurrent awakening, daytime sleepiness, fatigue, impaired concentration. Apnea, snoring, increased neck circumference, atrial fibrillation, non-dipping or reverse dipping of ABPM. This is very important. And obesity. Intermittent upper airway obstruction, overnight polysomnogram. Treatment is weight loss, CPAP, mandibular advancement device. So this is in a nutshell the treatment of obstructive sleep apnea. So 10 commandments help to avoid overweight and obesity, that is prevention. Diagnosis, suspect in case of snoring or visualized apnea or daytime sleepiness. Confirm the diagnosis, perform the sleep study. Quantify the sleepiness, BMI, apnea, hypopnea index, and nocturnal hypoxemia. Identify the comorbidities. Explore the upper airway. Establish a program to reduce weight. Start patient-specific treatment. Supervise CPAP, and a follow-up plan. In summary, OSA is one of the commonest causes of true resistant hypertension. It may occur in non-obese patients. High index of suspicion is needed. Clues may be found from history and physical examination, as long as we are aware what to look for. Polysomnogram is diagnostic. Treatment is effective to relieve symptom and hypertension. Prognostic benefit, unfortunately, is uncertain, but symptoms are definitely relieved. I stop over here and I give to Dr. Sinha what we can do next.
Thank you, Soumitra. It was a great talk, 2 cases, and both are very, very important. I would request any question from our students or junior doctors, anybody else. Somebody asked a question like, sir, please explain refractory hypertension. Refractory hypertension has been amply explained by Soumitra Ray.
No, sir, there is a little difference. Nowadays, the terminology, resistant hypertension and refractory hypertension. Resistant hypertension can be normal. If on 5 drug, your blood pressure is normal now, you are still resistant hypertension because originally pressure was not controlled with 3 drugs, including a diuretic. With the addition of 4th drug, now you control the blood pressure. But it is still resistant hypertension. But if you still cannot control the blood pressure, then it is refractory hypertension.
Sir, have you ever witnessed any patient of sleep apnea having dyslipidemia or any incidents of heart attack or CAD or acute coronary?
Yes, ma'am. We cannot see it, forward, but in retrospect, we see many of the patients who are admitted with coronary disease, particularly with heart failure, particularly with HEP patient, heart failure with preserved ejection fraction. Many of them, if you proactively do a polysomnogram, nowadays various, even the industry have offered us that, sir, we are doing the polysomnogram free of cost. Just give our telephone number. You get quite a few industry doing it. So if you do a polysomnogram in a patient of heart attack, in a patient of heart failure, in a patient of atrial fibrillation, and a patient of resistant hypertension, your yield will be very good. You can detect and you can change the quality of life of the patient by giving them or advising them the CPAP machine. It is actually a very good clinical thing, which we often miss. And the patient's quality of life is performance. Actually, one of my close relatives said that he is a very high-fi person in a very high corporate, and said, for last 1 year, I was losing my shin. I was not getting my target, and I was apprehending that I will be a bit diminished. And then I checked this. I reduced my body weight. I started taking CPAP, and now my growth curve again went like this. So my performance is so good. Because previously during lunchtime, I didn't know that I was sleeping. Even on my table, I was sleeping in my chair. While talking to my client, I was sleeping. So the quality of life and vis-a-vis, and which is also related to your performance, your social performance, your marital performance, your academic performance, and your official performance. All are affected. So it may not increase the longevity, but it increases so many things. Amlodipine is the first choice. How is cilnidipine in comparison? Yeah, that's an age-old question. Amlodipine is still the gold standard of DHP calcium channel blockers. All the trials of calcium channel blockers in hypertension which showed benefit came from amlodipine. But cilnidipine, ephonidipine, benidipine, these are all coming up. Most of them are not licensed in Europe or America. They're mostly Japanese or Indian type of products. But theoretically, they are not bad. You know that L and LNT, three types of receptors, and they're saying that if it can actually be beneficial for kidney. So I found my nephrology colleagues are very interested in giving the cilnidipine because it protects the kidney. Of course, the pedal edema is a bit low. You know why? Because amlodipine selectively dilates the precapillary arteriole in the periphery and afferent arteriole in the glomerulus. So more blood goes into the glomerulus as well as in the ankle, but they don't get adequate outlet to run off. So there is accumulation of intraglomerular pressure or fluid or edema. But this ephonidipine, cilnidipine, they equally dilate afferent and efferent arteriole or precapillary and postcapillary arterioles, so that whatever extra blood is going there, getting run off. So they're not accumulating in the glomerulus or in the ankle. So theoretically, intraglomerular pressure should not increase. Theoretically, ankle edema should be less. Theoretically, albuminuria will be less because amlodipine can cause albuminuria because there is increased intraglomerular pressure. But these are all theoretical. We haven't shown any head-to-head trial to say that heart attack, heart failure, stroke, or all-cause death or three-point MACE is really better with any of these newer CCBs, but they're handy to use because many patients stick to that because of less pedal edema, as simple as that.
Thank you. Just I wanted to, it came in my mind that would you think of residual risk when you are managing ACS, especially the recurrent ACS like situation? Will you think about residual risk?
Absolutely,
like
sir.
And what message do you want to give it to the students
I
here?
would say one thing, some of us get very much swayed away by the lipidology. And we think if we reduce the lipid from 80 to 50 to 30 to 10 to 0, we can stop all heart attack. But at some point, we have to stop and see whether we are missing something else than LDL cholesterol. Because you see that LDL cholesterol, I think reasonably if it is 40 to 50, and if there is recurrent cardiac event, then we must spread our vision to other parts of lipid, whether we are missing triglyceride, LPA, HDL, this kind of thing, or whether we are missing non-lipid things, protein C, protein S, factor V Leiden, homocysteine, whether we are missing these things, inflammation, CRP, whether we are missing these things which are incremental in putting ASCVD on top of lipidology. So don't be myopic with lipidology. You do reasonably everything to reduce the LDL, but once 40, 50, without fighting to go to 30 or 20, rather you spread your vision and see whether there is other areas which you can address to reduce the atherosclerosis.
So what do you see, or what do you recommend to
I
tackle?
recommend a holistic approach, sir. That lifestyle, smoking, body weight, stress and strain, absolutely important. We don't talk about the yoga, pranayam, and daily exercise, food habit, smoking, alcohol. these things are very, very important. And then we do a comprehensive check. You'll see in the ACC/SC guideline nowadays, there are risk enhancer. There is a column called risk enhancer. We should go to the risk enhancer and see whether our CRP level is high, whether our interleukin is high, whether we have got a connective tissue disease profile which is under control, whether our blood pressure is really controlled or not, etc., etc.
Then what do you recommend then if it is there?
We have to control those. Instead of giving all our resources to further lowering LDL, the money, the energy, we should go to check the blood pressure more strictly, blood sugar more strictly, body weight more strictly, stress and strain to address more strictly.
And a role
diet
of giving anti-inflammatory.
Anti-inflammatory area. Now, even this time with the ACC guideline of STEMI and non-STEMI, which came out only today, they said there is still a gap of our knowledge regarding the control of inflammation. And we are not very sure that whether we should reduce it by colchicine or not. We are not keeping colchicine on top at the moment. We have to wait for more evidence. So it is only today's version. So perhaps we have to wait for inflammation a bit more.
There is a question like, sir, what should we do if the patient has 12, 13 HbA1c level? Even with low dose of atorvastatin, I didn't get this question very well.
Sorry, will you please read it again? What do you do?
What do you do if the patient has 12 to 13 HbA1c level?
12 to 13 HbA1c level. Of course, you have to give insulin to begin with. Once it is reasonably controlled to 9 or 10, then of course you will give the disease-modifying drugs like GLP-1 receptor agonist, SGLT2 inhibitor, and other things that we know. Particularly these two for sugar are very good for heart and kidney. So you have to give these two at some point, but at 13 HbA1c, you won't start this because patient might go into ketosis. So you start with insulin, control the sugar, and then go into this.
Any other question from anybody or any comment?
Sir, a case of hypertension, thiazide in dyslipidemia, want it to worsen the lipids. Of course, chlorthalidone is slightly better than thiazide. It worsens the lipid, but we have got things to tackle lipid. Like statin increases diabetes, but we give statin. Thiazide increases lipid and diabetes, but we give thiazide because there's not much of good alternative because the loop diuretics are not very good antihypertensive to begin with. Unless there is renal failure, loop diuretic don't reduce pressure adequately and they have got a lot of other metabolic effects. So, but of the thiazide, we'll rather go for indapamide or chlorthalidone rather than hydrochlorothiazide to keep the risk minimum. Yeah, you're right that thiazides are not good metabolically. They increase sugar, they increase triglyceride, they increase uric acid, they reduce sodium, they reduce potassium. These are the 5 metabolic effects of thiazide. But if you use them in our country, I'll always recommend a lower dose, 6.25 rather than 12.5 and 12.5 rather than 25 to keep these complications to a minimum level. But you know, it is part and parcel of hypertensive treatment. You can't do away without it.
So if there are none, any other question? Then we are here to thank you, Dr. Samitra.
Thank you, sir.
Yeah, we are here to thank you all.
Thank you for remembering me.
All the students and API and Dr. Tiwari, I thank you very much.
One thing came from Dr. Neha Kumari, sir, best parameter among lipid profile to assess mortality. Still today, I'll say LDL cholesterol. Still today. Still today, I'll say LDL cholesterol.
Yeah.
Like in a you know, so in a Ramayana, still the main character is Ram. So it is still in the lipidology, still LDL cholesterol.
Another question has come like, what about PP triglyceride?
Yeah. Now triglyceride, PP is now very much in vogue. They say PP triglyceride is more risk predictor than fasting triglyceride. Only thing, there are two problems. One is we do not know how to standardize the PP assessment. Like you know that PP sugar, 75 gram of glucose, and you take after 2 hours. But how much fat is to be given? How long after that you will take triglyceride is not yet standardized. And number two, what is the cutoff level? We know that 150 for fasting, then 150 to 200, 200 to 500, above 500, we know the risk levels. But for PP, we do not know whether it is 300, whether it is 350, whether it is 175. There is no such standardization. But theoretically, epidemiologically, perhaps it is a better risk marker than fasting, but we have to wait for its standardization and to bring to the clinical practice.
So, shall we call it a day with a lot of big thanks to you? Thank you
Thanks
very
to
much.
all my junior colleagues and my teachers over here. Thanks for spending an hour together. It was
Thank
very
you all.
enjoyable.
We will meet again on 7th with Shraddha Ranjan speaking on echocardiography for the beginners. Yeah. So thank you all.
Thank you,
Good
sir.
night.
Good night, sir. And my regards to Dr. Tiwari as well.
Yes, yes. Yeah, of course.
Thank you.